Hi, this is Dr. Nick. I'm the Incrementalist. I'm delighted to be here with the President and CEO, Dr. Craig Samitt from Blue Cross Blue Shield. Craig, thanks for joining me.
Thanks for having me. Good to be with you.
So you spoke at the World Healthcare Congress. Tell us a little bit about that presentation and what you were talking about.
So I think that I was probably the old incumbent who's a bit irreverent and impatient about pace of change.
I think we all are, aren't we?
No, I think so. Maybe that's, I love the World Congress, but I come back and I hear the same talk that I heard a year ago, 5 years ago, 10 years ago, and 20 years ago. And so my thing is a passion for transformation of our industry, and I just want to get on with it. We've been talking about the need for change. We've been talking about the imperative to shift to value. And in my book, we're not moving fast enough.
I agree. So how do we move faster?
Well, I mean, I think a lot of it is about taking risk and being bolder. We can't be incremental in driving change. We all say we're going to go back and think about change as opposed to acting on it. I think one of the things that our industry is best at is admiring our problems. And we're not very good at actually addressing them. So in Minnesota, where people don't realize that Minnesota is about the same size as New Zealand. New Zealand has done some very transformative work in healthcare. There is no reason why Minnesota can't lead the nation in rethinking the entire care delivery and care coverage model. We care for 3 million people today. We can do a lot of change with 3 million people by reinventing and trying a bunch of different things in the industry.
I'm testing my memory, but I want to say that might be at least on par or probably more than the population of New Zealand, right?
Yeah, I think it's comparable. It's about a comparable size.
Right.
And New Zealand has done some really transformative work in provider partnerships and care model reinvention. And those are the exact sorts of things that we want to do in Minnesota as well. Our focus, frankly, is improving health by reinventing healthcare one problem at a time. So when we think about the problems that we admire, we're not as service-oriented as we could be. Our quality is high, but we're unaffordable. So we need to start thinking, even in many respects, like other industries. I'm one to say, well, maybe we shouldn't benchmark ourselves against healthcare, but maybe we should be the Costco of healthcare, the Netflix of healthcare, and the Uber of healthcare.
And I think you bring up an interesting point. One of the things that we're seeing with the silver tsunami, and that's the areas of hope that I have,
right,
is that they're entering the the medical system, starting to access care. They don't check all of their personal experiences at home with Netflix, FedEx, and all of those things, and go, "Oh, right, yeah, sure, I'll fill in a paper form and do all of these things." They expect the same level of services and experiences, but we're not giving it.
I think that's exactly right. I think that if we copied, I shared in my session earlier today that I don't necessarily think that innovation is a problem in healthcare. I think imitation is a problem. And to some degree, we need to imitate from each other because there are some examples of excellence in healthcare. But I also think more importantly, we have to imitate what other industries have done that are relevant to healthcare. And if we plugged all that into our industry, I think healthcare would change. So we need to look at our payment model, we need to look at our service model, we need to look at the use of technology and data. And frankly, we may have to reinvent something like care delivery from scratch. Maybe we need a new primary care model that does things a little bit differently than what we're used to.
And you have an opportunity to essentially reinvent that whole system within the state.
We do. The beauty that we have of being about a 3 million member plan is we're not so big that we're old and stale and bureaucratic, and we're not so small that we don't have scale. So Minnesota is of a perfect size to really experiment.
So one thing I got to try and push you a little bit on is this whole incremental, because my personal view is that we can reach that big leap, but we do so through small changes, but do so rapidly. So do you see a pathway that has incremental changes to that leap across the chasm?
Yeah, the one that I would pick is sort of the evolution of value-based payment. I think I would say that the ACO model has been successful
It has.
in that it moved people out of their comfort zone and began to pay clinicians for things other than just volume.
Right.
The problem is we're now stuck at the next place. So in many respects, we can't be stale again. We need to keep moving. So I think transformation could be a series of incremental steps.
Right.
but they can't take a decade until we take the next step. We need to take a next step the following year and keep moving organizations more in the right direction. I'm just worried that we're stuck yet again in where we're at.
So I think what I hear is that this is an incremental improvement, but the key learning point from an incremental standpoint is incremental steps don't stop. It's this continuous process.
Yeah.
And when it's wrong, correct it, but keep moving and keep making progress.
I've been using the term relentless evolution.
I love it.
And so maybe instead of incrementalism or transformation, relentless evolution implies that we're just going to keep changing.
Incrementalism is a revolutionary concept that I think we're going to see out of Blue Cross Blue Shield from you.
Yes, very much so.
So thank you very much for joining me, Craig. It's been a great pleasure.
Thank you for having me.
I'm Dr. Nick. I'm the Incrementalist. Don't let perfection stand in the way of progress. You heard it right here from Blue Cross Blue Shield and Dr. Craig Samet. Hi, this is Dr. Nick. I'm the Incrementalist. I'm delighted to be here after Dr. Marty Makary's talk this morning at the World Healthcare Congress, talking about the price and the challenges in the healthcare system. Marty, just briefly for the listeners, explain what you were talking about and the challenge of this pricing mechanism and what you see as the solutions to the way that we can fix this broken healthcare system.
Well, as you know, Nick, there's no silver bullet to healthcare, but if we had to summarize two of the main issues in healthcare, I would say it's the appropriateness of care,
right,
and it's pricing failures. It's doing too much medical care or sometimes undertreatment, too little care when it's needed. It's that appropriateness threshold, and it's also the fact that people deserve a price when it's a shoppable service. Now, if somebody gets shot in the heart, we're not going to give you a price, we're going to take care of you. But 60% of healthcare is entirely shoppable. That is, we can provide a price, it's just that we haven't done so because it hasn't really been required of us by the market. There hasn't been the demand. Instead, we've done these global discounts. We collectively, as a healthcare community, have functioned by global discounts to insurers. Patients are now paying a large stake in the bill, and they're getting hammered, and they want some transparency. They want to know what is a fair and reasonable price, and what's the best price you can give me. Now, I can tell you, people are willing to pay more for quality, but they want honesty in pricing.
So one of the things you talked about in your presentation was the level of interest and focus now from a political standpoint, and I think what I heard you say was this is going to be the primary issue for the upcoming elections. Do you think that that's the case, and what's that going to do? How's that going to drive change?
Look, I've talked to hundreds of people who have been patients and are now struggling with a medical bill as a part of this national tour for the book, The Price We Pay. I visited 22 cities and talking to people on the ground, at the hospital level, insurance level, pharma level, you name it. Overwhelmingly, the voice I heard is that patients are getting hammered right now. They're getting hammered with bills they can't afford, that are overpriced, they're marked up, they're surprise bills, they're out of network care delivered at in-network facilities. People are mad. Right. And I think they have a right to be mad.
Look, I'm mad too.
Look, as a physician, you know that medicine is a beautiful art, and we have an incredible profession. The heritage of the medical profession is beautiful. But that public trust, which has been sacred, is now being eroded by predatory pricing and inappropriate care in the marketplace. And I think we need to speak out about it, and I think we need to, the centers that are doing the right thing and are billing fairly, which, by the way, is most of the centers out there. They're doing the right thing, or they're trying to. They need to broadcast that, and we need to create a market that rewards that good behavior.
So I just want to call you out specifically. You mentioned something really interesting to me that I think we need more Marty Makarys, because what you said was anytime you're involved where patients were being overbilled, essentially balance billing, all of those practices, as soon as you got involved, the cases were canceled, right?
Well, what's that tell you? When a hospital drops a bill because they see that I'm getting involved now and advocating for the patient, or I call the CEO and say, hey, the patient got overcharged and you would happily accept a fifth of this money from Medicare. So why are you going after the low-income people? It used to be that the people paying out of pocket were uninsured, and the medical establishment, blamed them and said, "How dare you not have insurance?" It's now everybody. Everybody is getting hit with high deductibles.
Yep.
And so let's stop blaming the patient. The people I've been defending in court with these medical bills where the hospital goes after their wages and puts liens on their homes, these are working people.
Right.
They don't qualify for public funding. They don't qualify for Medicaid. They make too much money, $22,000, $28,000.
Too much money. Think about that.
Yeah, ironic. And they have insurance. So what did they do wrong?
Right.
They are working hard. They're single moms. These are, people who work for a living. I don't even think I work. I mean, I love what I do. I wouldn't even call it work. The person who's, going in and struggling and making it paycheck to paycheck, that's a very different life than what many of us in the medical world
experience
connect with. And I have been struck in doing the work for the price we pay. People are getting crushed out there.
So it just remains for me to thank you for being the advocate, for fighting for those patients. For those of you listening, The Price We Pay, important book. There's a new version of that coming out. Marty, thanks for joining me today.
Great, thanks. Good to be with you, Nick.
I'm Dr. Nick, I'm the Incrementalist, and I'm here at World Healthcare Congress with Dr. Marty Makary. Hi, this is Dr. Nick, I'm the Incrementalist. I'm here at the World Healthcare Congress. Very excited to be with Dr. Robert Pearl. Thanks for joining me, Robert.
Hey, Nick, great to be here today.
So tell me, you wrote a book a while back.
I did.
Mistreated. There were some key concepts in there, I think. We're all suffering the poor experience of the healthcare system. What did you learn through that experience of writing the book?
So I started the book actually when my dad died from a medical error.
I'm sorry.
Yeah. One of 200,000 people that year and every year. And then when I add on top of that the number of people who die from lack of prevention, complications of chronic disease, we have 500,000 people dying every year prematurely, and the most expensive healthcare system in the world.
Right.
And so that was the focus of the book. And the conclusion of the book is that there's 4 pillars that support a roadmap to the future. And one is going to be integration. I don't see that physicians can take care of patients isolated in their office alone. I think it's got to be horizontally within departments, vertically between primary care and specialty care.
And with patients, right?
And with patients, absolutely. Yep. Number 2, I don't believe that fee-for-service can work. It's interesting. I'm a keynote speaker at a lot of conferences, and I always ask the audience, how many of you have remodeled your kitchen? Oh, a lot of hands go up.
Right.
How many of you just told the contractor, come on in, do whatever you want, I'll pay you time and materials? They laughed, like you're laughing.
Yeah, no,
right?
absolutely.
Yeah.
Well,
do we think doctors are just more honest than contractors? No.
Right.
Because what we find in the book is that context shapes perception changes. Fee-for-service, I don't think can work.
Right.
Capitation is necessary.
Right.
You can get there incrementally through some kind of bundled payments and some other ways.
Right.
But ultimately, I think the goal has to be capitation. The third is technology. I teach at the Stanford Graduate School of Business, and in this first class, I say to my students, what do you think is the most common way doctors in the United States today communicate with each other? They, of course, have no idea. It's the first class that I teach. And I tell them, it's the fax machine. You know what they say?
What's
that?
A fax?
Exactly. And that's the way we communicate.
Right.
And then finally, leadership. Tell me another industry that has no real leader over all the things that happen in that business. And so I think those 4 pieces, and the challenge and the fact that you're leading an area of incrementalism, I think is amazing, because I know how tough it is to do the whole leap.
Right.
The question is, will we get there incrementally?
Yep.
Because, again, I consult to a lot of medical groups, and when I tell them what you're going to have to do is to give up your redundancy, give up your unnecessary procedures, give up your prolonged hospital, they say, we can't afford to do that.
Right.
And so the question is, how are we going to get from here to there?
Right.
And however we get there is fine, but I think until we get there, we're going to see small change. It's not that it's bad. It's just not what we need to make America's healthcare system a great one again.
So, I think it's important to bring out the point that we were talking beforehand, and you're looking for those big leaps. They're important, and I don't disagree with you. I think the big leaps. I was a product of the space age and
Sure.
Kennedy's famous speech.
Yeah.
The inspiration, but I would point to NASA as another example of this, where they made it, but it was all these little steps.
Sure.
And if you look back at the history, and I feel the same is true in healthcare, and what you describe as those 4 pillars, albeit they're relatively 4 big pillars,
Yeah.
we can find steps within each of those to allow us to get there. All we have to do is to do it quickly and keep going.
Yeah.
Don't stop.
Well, quality is one area where I think you can get incrementally better. In fact, I think you have to get incrementally better because there's no finish line. So as an example,
good point.
Hypertension across the United States is controlled 55% of the time. When I was the CEO in Kaiser Permanente, we controlled it 92% of the time. I controlled it 92% of the time because we were integrated and capitated and had the technology.
Right.
But you can go from 55 to 60 and 60 to 65.
Right.
There's nothing along that pathway for which incrementalism is not only not good, it doesn't work really well. Same thing when it comes to screening for colon cancer. We screen 90%, the country spends 60%. That's 100,000 people dying every year unnecessarily or prematurely. Actually, unnecessarily, because we can actually prevent it in half the cases.
Absolutely.
All right? And there you can go from 60 to 65 to 70. Why I push the 4 pillars, and to me, the colon cancer is a great example. All right. What we know is there's 2 ways to screen for colon cancer, right? There's colonoscopy, and some variant, I call it a FIT test, fecal immunochemical test. All right. One, you got to have a whole day of laxatives and diarrhea, followed by another day missing work of a general anesthetic and a possible colon perforation.
Right.
And a FIT test is 5 minutes, privacy of bathroom, no prep, once a year. How many GI docs in the United States today, when a patient shows up and doesn't have an indication like a family history or a previous polyp, says, let's do a FIT test, let's not do a colonoscopy? I dare you to find me one.
So what is it that's stopping them? Because I understand that, I get that.
Sure.
Why is that not happening, do you think?
That's why I say it's the economic system. Because when you get paid $3,000
right.
versus $50, you perceive it differently. It's fascinating to me they had the choosing wisely, which I think was a brilliant idea, and in many specialties it worked very well. The ophthalmology group, you know what I'm talking about with choosing wisely? Yeah. The ophthalmology group came up with 5 areas, not a single one of which involved the eyeball. They said no EKGs before cataract surgery. There's a bunch of other things. I mean, how could they not understand that? Or urology. Look at the literature on PSA and how we think about the screening and the approach to it. The context shapes the perception, changes the behavior, and money is a big driver. And again, that's why I go back to this notion of moving. Now, you can go incrementally. You can start bundling some payments, bundle some diseases. I have a lot of confidence in some of the big primary care organizations in the United States today that have taken the most complex patients, the Medicare, Medi-Cal, Medicaid, double insured, and they're doing exceedingly well from both a quality and financial perspective. So I agree with you. There are incremental steps, but I don't think we should ever lose where the end point's going to be.
No,
if not, we'll stop along the way.
You have to have that far point, that aiming point. And what you remind me of in there is the system is working as designed. If you follow the money and the incentives, everybody's working. And not that they're doing so in a negative, we're just conditioned that way. That's inevitable. So we have to change the surrounding incentives so that everybody changes accordingly.
That's the business school perspective. Show me your economic model. And I'll tell you the outcomes you're going to get. Pay people on a piecemeal basis, a fee-for-service basis. You'll get kitchen cabinets you didn't need. You'll get things done to your car you didn't really want. And you'll get procedures done. What do we know? We know that 30% of what doctors do in the United States today don't add any value. And yet, orthopedics is a great example. The most common in operation, knee scope and trimming, no better at 1 year than simply doing physical therapy. Why? Because when you get paid a lot of money to do that procedure and you don't get paid to tell the patient to go to physical therapy, same process is sitting in play. And so, I think your idea is a great one because you can pick off pieces that you can start to address. But until you actually do address them, and I think until you actually put all 4 pieces together, what we're going to find is we make progress, not bad, but we don't really get where we need to go. I think we can have 30% higher quality, 30% more convenient care, and 30% lower cost. It's within our reach today. We just have to decide we're going to do it.
I just want to say, he said he thinks it's a great idea, incrementalism. So Dr. Robert Pearl said that, so thank you.
Thank you so much.
Robert, thank
Nick,
you very much
so
for joining me.
It's been a pleasure.
Great pleasure.
Good luck.
I'm Dr. Nick. I'm the Incrementalist. Don't let perfection stand in the way of progress. Hi, I'm Dr. Nick. I'm the Incrementalist. I'm here at the World Healthcare Congress. Real delight to be with the Honorable Dr. David Shulkin. He is a prior administrator for the Veterans Administration, and I would say an innovator. When I look back at some of the things, you were an early creator of Doctors Quality, which was one of the first consumer kind of level reports that focused on healthcare quality. Tell us a little bit about your journey to that point.
Well, first of all, I'm a doctor, and that's the way I think about helping patients and helping patients make the right decisions. I'm a primary care doctor, and I've always believed that people need information to make good decisions about almost anything in their life, and so healthcare should be no different.
Right.
And so early on in my career, I was a big believer that we needed to know more about the quality of care that we have, the cost of the care that we have, and informing and educating patients was just something that I believed in, and glad to see that slowly but surely we're getting there. We still have a long way to go, though.
Right, and that's interesting because I can talk to a number of physicians who would take a counter position and keeping patients out. You're clearly in the patient engagement camp and the opportunity that builds and the value that they bring to the care, right?
Well, I certainly hope there aren't a lot of physicians who believe in keeping the patient out. I think that's an older way of thinking, and I think most doctors understand that in order to get the type of outcomes, the best outcomes of care, that it needs to be a partnership, and including people in their decisions is not only a right, but also the best way to help people.
I think, as Leonard Kish said, patient engagement, blockbuster drug of the century, so the real value proposition. Tell us a little bit, you presented here, what were you talking about?
I was talking about my experience in the federal government. I worked for both President Obama and President Trump, and being a member of the cabinet was a real honor to be able to help lead the largest healthcare system in the country, and what lessons I learned from that experience that I think the private sector can learn from.
So, that's interesting. One of the things that, we're hearing a lot about is Medicare for all. And, is there some model that you see where we could take the veterans system and offer that as a broader kind of capability? Can we learn from that?
Well, I don't think what we're looking to do, and I don't think that we want to propose that we take the veteran system and expand it for all Americans. I think the veteran system is designed because our veterans deserve a certain level of care, and we have a responsibility to that, so it should stay designed for them. But I do think there's a lot that we can learn from the lessons of the VA that we can take outside to help all Americans. And I think the concept there is, Medicare for all is a concept that would help improve access, but it would still retain the current fee-for-service system and many of the problems of fragmentation that we see. So I think what we want to do is better than that. I think that the approach that I believe in is taking a population of patients and being able to actually provide population health approaches towards that, so that you can tackle issues, you can use data in a way that helps you improve care, and you can assign accountability for the improvement of the health outcomes of the population. So I hope that we're moving towards that direction, and of course CMS just announced a new initiative where they're exploring that, and I applaud them for that. I think that's the right direction.
So if you could think of, long career, you've looked at this, you've worked in a system that essentially delivers good care, covers this large population. If there was one thing, small thing that you could change in our current system for the rest of the population, is there anything that springs to mind that would really, help push us over the edge and get us towards this goal of a better, improved healthcare system that's delivering value for money and great care?
Yeah, well, anytime somebody says, "Is there one thing in healthcare?" I try to avoid that, because of course, there is no one thing. But first of all, I think the focus on access has to be the primary focus. Until we get all Americans the type of access to care that they need, we're going to be a lacking system. I think that in my career, transparency of information has been absolutely critical, and we need to do much more in terms of that, and that's something that I think can be done quickly and done without too much cost. And then we need to make sure that we get our payment systems aligned. Wherever you have a clinical system and clinical approaches that are not aligned with the financial system or the business model, you're never going to get the outcomes that are optimal. So I think those are the areas I'd focus on.
So in fairness, I put him on the spot. I asked him for those 1 or 2. And in fact, he came up with 3 great incremental steps, I think, to really sort of set us on a path. Great pleasure, real privilege to talk to you. Thank you for making the time.
Glad to do it.
I'm Dr. Nick. I'm the Incrementalist. Don't let perfection stand in the way of progress.